Good afternoon, everyone. This is Yvette Kelly with the Community Technical Assistance Center, and I'd like to welcome you to today's webinar, Substance Use Disorder, What You Need to Know. Before we get started, I want to take a moment to orient everyone to the WebEx system so you know how to participate in today's event. If you have not done so already, please call into the webinar using the audio conference information tab found in the event info, and you can find this tab above the slide deck to your left. Upon joining the webinar, you'll be placed on mute to avoid any background noises that may distract others from listening to the webinar. And if at any time during this presentation you come across any technical issues, please chat to the host, Brianna, who should be able to assist you. You will also have the opportunity to submit questions to today's presenters by typing your questions into the chat box, which is located on the right-hand side of your screen. If the chat box is not visible, click the dialog bubble on the top right toolbar and it should pop up. You may send in your questions at any time during the presentation, and we will address them during the Q&A portion at the end of today's webinar. We ask that when you are chatting questions that you please chat into all panelists. All right, so today's webinar, Substance Use Disorder, What You Need to Know, will be the first webinar in a series of webinars where we discuss the basics of the disorder, principles of addiction as a brain disease, symptomology, prevalence, availability and access to effective care, as well as talking about dispelling some of the common misconceptions and biases about substance use disorder. I also want to spend a few minutes just to let you know who we have with us today, who will be joining us. We have partnered with the National Center on Addiction and Substance Use, who are experts in the fields of substance use and addiction, and will be talking with us today about all of those things we just mentioned. I also want to let you know who we are from MICTAC. For a lot of you who are signed on, I'm sure you've probably joined some of our other webinars, but also want to let you know that we are an educational resource center for both behavioral health and substance use providers in the state. And so just to give you a little bit of background about the presenters today, we have Marcus Doherty, who's the Assistant Director of Healthcare Reform Consultation at the National Center on Addiction and Substance Use. Marcus has over 25 years of experience in the fields of addiction and mental health, and again, we'll be sharing that experience with us throughout the presentation. We also have Tiffany John, who is a licensed mental health social worker, her position is a research associate at the National Center on Addiction and Substance Use. And again, she has experience delivering behavioral health services to youth in residential and criminal justice settings. Without further ado, I am going to turn it over to our presenters so they can begin to lead us through the presentation.
All right, thank you. And I'd like to start off by just introducing myself. My name is Marcus Doherty, and I'm part of the MICTAC team here at CASA, which is the National Center on Addiction and Substance Abuse. And I'd like to welcome everyone to the presentation today. So as was previously mentioned, what we'd like to talk about today is really substance use disorder, kind of like an introduction, and we kind of want to talk about it from a definitional perspective, what is addiction, and then we'll talk about some of the science behind it, and also we'll talk about some of the prevalence, which will be discussed by my colleague, Tiffany. So in terms of what is addiction, let's look at the definition here. Okay, and in terms of addiction as a definition, from a science perspective, we really see it as a chronic manageable health condition characterized by compulsive drug seeking and use despite harmful consequences. And drugs change the brain, its structure, and how it works. So we're really going to focus on the science and the biochemical changes in the brain that really define addiction from a science perspective. And the other thing I'd like to mention, too, is that when we talk about addiction from a biochemical perspective, some of the changes that we're seeing are really long-lasting. So what addiction is not, okay? And basically, it's not a moral failing, and it's not a character issue or a failure of will. Now, this is really important historically because up until really the science aspect of addiction, we really looked at addiction from a, you know, you can really stop, this is a character flaw, this is a failing on your part. So the science has really shown that it is a brain structure issue, it is a biochemical issue, and it is an issue that is really biochemical as opposed to a moral failing or an issue of character per se. And addiction is not something that just good intentions or your willpower can just stop. Okay, so we're going to talk a little bit more about that, and in future webinars we'll talk about the treatment behind that. But the main issue from this particular slide is that I want you to take away is that addiction is not a moral failing. Okay, and that has implications for treatment, and we'll talk about that in future webinars. So let's talk about addiction from the disease model. Okay, so one of the things to keep in mind is that addiction is really a complex brain disease, and what we'll talk about in future slides, just to get ahead of the moment, is that we're going to focus on the dopamine pathway, but we know that there's other pathways that are also implicated in addiction as well. But just keep in mind that it is a complex brain disease, and drugs like nicotine, alcohol, illicit drugs, and controlled prescription drugs all affect the pleasure and reward circuitry of the brain in similar ways. So we're going to talk about the brain circuitry in terms of the dopamine pathways in a few moments. But in terms of a model of addiction from a disease perspective, keep in mind that the main part of the brain that's affected is the pleasure and reward system. Okay. The other thing to keep in mind is that over time, continued use of substances can physically alter the structure of the brain. Okay. And by physically altering the physical structure of the brain, that also impacts on one's judgment and one's behavior. So, the reward circuit. The body's reward circuit really controls how one feels, okay, which speaks to pleasure, and also speaks to one's level of motivation. Okay, so as you continue to use substances, very often it brings you to a place of pleasure. And as the substance decreases from your body, what you're seeking is that same experience of pleasure. So you have to use more and more of a substance to get that same level of pleasure. And this is very similar to activities that we have that we normally go through. For example, eating, drinking, water, having sex. All those are pleasurable acts that are also influenced by brain chemistry. So the analogy would be when we introduce a substance into our body, the reward circuitry is impacted in the same way. Okay, and this is what we consider to be a high. So the level of pleasure is what drives someone to take the substance again and again and again. And we have some terminology for that we're going to also go through shortly as well. So as I mentioned a few minutes ago, the dopamine pathways is one pathways that we refer to when we talk about the reward circuitry. So in the dopamine pathway, as someone uses more and more drugs, the brain has to adjust to the excess production of dopamine in the reward system. So one way that the brain adjusts is by reducing the ability of the cells and the reward circuit to respond to the dopamine. So this is very similar to if a drug is introduced into the body and it's impacting the dopamine pathways, what the neurons will do is they'll decrease the production of dopamine into the brain because it's interpreting and it's realizing that dopamine is already being introduced into the system. So what happens is when you decrease a substance use, now you're not feeling that pleasure at that level. So what happens is you need to have more of the substance introduced into your body, particularly the brain, to get the same feeling of pleasure. Okay. So this is why one would need to take more and more of a substance so that they can try to recreate that first high. So one of the comments I'd like to make in this particular slide is it's very often people that are using substances would experience a high like they never experienced it before. And then once that high dissipates, the whole concept of addiction is that you always want to get back to that first feeling of being high. And that's something that users want to reproduce and reproduce and reproduce. And that system, from what we know in terms of a definition of addiction, really speaks to the dopamine pathways. Okay, so on this slide here, you should see a diagram of the brain and the example of how drugs of abuse increase dopamine. So on the far left, you just see a half structure of the brain. And then the middle slide, you see where the intake of food would activate the dopamine pathways. And then if you look at the far right slide, where you see the introduction of cocaine, you can really see the increase of dopamine production, okay? So if you can just imagine when the cocaine is taken away from the body, or if you decrease the use, then you can really see where the need to get that same experience from the cocaine would really lead the person to want to use more cocaine and get back to that same high again. So this is what that slide is kind of demonstrating from a food versus substance perspective or drug perspective. So when we talk about chronic drug use, what we're really talking about is that when someone abuses drugs and alcohol to the point where they now have permanent changes to the brain's functioning. And there are certain terms or certain descriptions of that type of permanent brain functioning that we get to. One is what we call tolerance, okay? And tolerance simply means one has to use more and more amounts of the substance required to get the same effect. So this is somewhat what I was talking about a few minutes ago, where in the dopamine pathways, one of the ways that the brain responds to the intake of a substance is to decrease the use of dopamine. So by decreasing the use of dopamine, the individual now needs more of the substance that was originally introduced to get the same effect. So this is really what tolerance is. Okay, so really it's just wanting or needing more and more of the same substance to get the same effect. Now, dependence speaks to an inability to function without the drug. So what we're talking about here is someone that really has issues with functioning, maybe getting up, being to work on time, dealing with personal hygiene issues, just dealing with anything that impacts the ability to function on a daily basis. So that's what dependence is. And dependence is really a function of the drug use. So the person needs the drug or needs a substance in order to function at some minimum or functional level. Okay. Another aspect of permanent changes to the brain is what we call dysphoria, which is excessive and negative emotions, which can lead to relapse. So a person that maybe has stopped using may have negative emotions. They may feel agitated. They may feel irritated. And that can lead to a relapse because, again, you want to get back to the same high or the same pleasurable feeling that you had when you was using the substance. Okay, the next term is what we call sensitization, which really speaks to greater responsiveness to a drug. So, for example, if someone had stopped using a substance for a while and they went back to it, they're going to have a greater responsiveness to that drug. It's probably not as sensitive as the very first time, but they're going to have an increased responsiveness to the drug. And this is what makes people more likely to relapse if they have gone for a period of time without using the drug. Okay, so these are the four terms that can result from chronic use, which results from permanent changes to the brain's functioning. So you have tolerance, dependence, dysphoria, sensitization. And on this slide here, you see some of the long-term effects on the brain. Learning, judgment, decision-making, stress, memory, and behavior. And once again, these are long-term effects from chronic drug use, which results in permanent changes in the structure of the brain. Okay, at this point, I'd like to turn our webinar over to my colleague, Tiffany, who will talk about the prevalence of substance use.
Hi, everyone. Good afternoon. As Marcus said, I'm going to just switch gears a little bit and talk about some different rates within adults and adolescents. So overall, according to the most recent data that we have available, around 20 million Americans need treatment for substance use disorder, meaning that they meet criteria for substance use disorder, but not that they're necessarily receiving any treatment. And this breaks down to about 1 in 7 people nationwide. And I'm sure we're all aware that we're kind of in the midst of this opioid epidemic, and that's really leading to a lot of drug overdoses. And so in 2015, overdoses actually surpassed both gun homicides and car accidents. And so that's about 144 people are dying per day of an overdose. Okay, sorry for that slight delay. So in adolescence, we're going to talk a little bit in a few minutes, but younger use puts someone up for more of a risk of developing addiction. So 9 out of 10 people who misuse or are addicted to nicotine, alcohol, or other drugs began using before they were 18. And about 1 in 8 high school students meets the clinical criteria for addiction, and among students who have used an addictive substance in the past month, according to one survey, 1 in 3 already meet the criteria for an addictive disorder. And since we're talking about opioids and what's going on in the current landscape, currently over 1,000 teens try a prescription killer for the first time daily. Okay, so I'm just going to talk a little bit about the prevalence of co-occurring mental health and substance use disorders. And what this term means is when it presents an individual that has both a mental health disorder and a substance use disorder at the same time. And it's important to look at this because compared to the general population, someone with a mental health disorder is more likely to also have a substance use disorder. So this chart shows for someone who has either a diagnosis of a substance use disorder or a mental health disorder, what those overlapping is. So in 2015 is what we have the most recent data from. There's about 19.6 million adults who had a substance use disorder, and about 41% of them had a mental health disorder as well. And then on the flip side, for the 8.1 million adults who had any mental health disorder also met criteria for substance use disorder, and that's 18% of that population. And I just want to talk about this because they can be complex to diagnose, because some of the symptoms can present as either mental health or substance use disorder. It's going to be hard to tell which one occurs first, so it's important to screen for both of them, and that to treat both substance use and mental health at the same time, and we'll talk more about that in our later series of webinars. And this is just broken down by age. There's not a figure up here for adolescents, but for adolescents, about 75% of youth that have a substance use disorder also have a co-occurring mental health disorder. But unfortunately, only about 1/3 receive treatment for both conditions. And in the adolescent population, the most likely co-occurring disorders are conduct disorder, ADHD, depression, anxiety, or post-traumatic stress disorder. And then in adults, it usually manifests as depression, anxiety, or schizophrenia are the more common ones. So we're going to talk briefly about what are some risk factors for addiction. So no single risk factor can determine if someone will become addicted to a substance. Everyone is different and reacts to drugs and alcohol in a different way. So it's impossible to really tell if someone is going to develop addiction, but research does show that there are a number of factors that can increase the likelihood. And the greater number of risk factors someone has, the more likely they are to develop a substance use disorder. And as I mentioned before, one clear and consistent risk is early age. And individuals who use any addictive substance before the age of 15 are 6.5 times as likely to develop an addiction as those who delay until age 21 or older. So this next slide kind of really shows that how the risk decreases each year that initiation of substance use is delayed. So really we want to highlight that it is important to delay use of a substance for as long as possible to decrease the risk of addiction. So I'm going to talk a little bit about the adolescent brain and why this risk is so high. So the teen brain is still developing. Brain research shows that about 25, 26 years old is when the brain is still kind of developing. So the brain is plastic, which means it's more easily altered and affected by the use of drugs. So drugs affect it faster than an adult brain, and then also more intensely. So the regions of the brain develops from the back to the front, and the regions that Marcus was talking about earlier, the ones that are responsible for judgment, decision-making, and emotion are not quite fully developed until early adulthood, but the part that responds to pleasure and reward are more developed. So like that area is outpacing the development. So the reward is not as fully developed as the consequence center, or like the part of the brain that really thinks about what is going to happen if I do something, or I know I should stop, enough is enough. So the analogy we like to use here is like a car with a very sensitive accelerator, but pretty bad brakes. So therefore, adolescents are more likely than adults to take risks, including addictive substances. And also, since the brain is still developing, The dopamine pathway that we talked about earlier, that is still more, it's like more sensitive to the rewards and less sensitive to risks. So as I said, compared to adults, this really helps. So they're more sensitive to the dopamine, and that pathway is altered the permanent structures more quickly than an adult brain. And because of this, any other risks that the adolescent may face during this time has a higher impact than an adult as well. And I just want to talk briefly about peers, because peers kind of act on the dopamine pathway the same way that any other thing would, but it reacts differently for teens. So for an adult, just hanging out with your friends, you're less likely to be affected, but for the teen, it's not necessarily peer pressure, but just responding to, they can respond to the emotions of their friends are more motivating, so it's more wanting to please other people and like feeling judged a lot more than an adult. So studies show that just by being around friends, teens are more likely to engage in risky substance use and other risky activities. So back to just other risk factors for addiction. It's kind of like an interplay between your environment, genetics, et cetera. So genetic predisposition or family history of substance use is a very high part of this piece, and it accounts for about 50 to 70% or 75% of risk. Adverse childhood events such as trauma, abuse, and neglect, or even stress, especially in younger children, or if it spans over a long period of time from like early childhood through adolescence. Having a co-occurring mental health or behavior problem is a high risk for a substance use disorder, peer victimization or bullying, any other risky behavior. And then some groups and populations are more at risk than others, such as anyone involved in child welfare, juvenile justice, having dropped out of school, or having a minority sexual identity. Research shows that there are protective factors that interplay with risk factors, and having more protective factors can help reduce or offset some of these risk factors. So a main one is having good self-regulation and impulse control. So interventions that target strengthening these can have a really good effect. Having positive family environments, such as strong parental support and strong family involvement, or like another positive adult or peer role models, limited accessibility and exposure to addictive substances. So if you're in an environment where you are not as likely to be exposed to substances or have access to them, and then also just having a strong sense of connection to a community, be that school, other things in your community such as religious organization, extracurricular activities, and then being future-oriented. And that really means just having some future goals and a direct path. I'm going to talk about the consequences of substance use and addiction, and these really span from individual to family to even societal consequences. So early death, as we know, there have been a lot of overdoses are on the rise, but then also accidents, homicides, and suicides can be related. Poor academic and job performance are another consequence, having low grades, dropping out of school, and that kind of really impacts a youth's developmental trajectory, what they're able to do in the future. Also, poor health outcomes. Along with it being a risk for a mental health co-occurring disorder, also physical health disorders often go hand in hand with substance use disorders. And then also, you're more likely to have a traffic accident, engage in risky sex, brain damage when using substances. And then crime is often associated. So societal costs. Addiction is the largest preventable and most costly health problem that we face today. In 2009, addiction and risky substance use cost the U.S. government at least $468 billion. And this spans across many systems, such as the child protective system, correction systems, the judicial system, and healthcare systems. And then in 2013, the cost of opioid use, abuse, and overdose was about $78.5 billion. The good news is substance use is treatable, and as Marcus talked a little bit in the past, some of the stigma that went along with this was it wasn't viewed that way, but we do know that there are evidence-based treatments that can be effective in managing addiction as a disease. One thing to talk about is relapse is inevitable and can, well, not inevitable, but it can occur and should not be seen as a sign that treatment does not work. It's just that it's a sign that treatment should be ongoing and should be adjusted based on the patient's current status. And relapse is also seen in other diseases such as diabetes and hypertension, so addiction should be treated in the same way that we treat other chronic diseases. And that it's really important that the appropriate level of care and treatment needs are identified and that a full continuum of services are available. And this is something that we're going to talk about further in our next webinar. So just to wrap up, we're going to review what we've talked about today. Addiction is a medical condition. It has roots in biology and the brain structures. And it's not about criminality or a failure of will or a moral failing. Treatment is preventable and treatable. You can identify what risks and try to minimize those and increase protective factors and provide evidence-based treatments, and that it needs to be managed as a chronic condition and not treated in an acute care episode. And so, yeah, I just want to thank you, and we can move on and be on the lookout for our next webinar. But we'll hand it back over to Yvette for our Q&A.
Thank you, Marcus and Tiffany. We are now going to, I'm sorry, here I'm getting a little echo, but we're now going to be moving on to answer the questions that were submitted during today's presentation. Just as a reminder to everyone, you can still submit your questions, and we will give the presenters an opportunity to answer them. So one of the questions that we did receive was regarding some of the statistics that were presented. And the question is the statistics for overdose just unintentional overdoses or for both unintentional and intentional?
I would want to look that up to be sure that I'm answering this correctly, but I do believe that it's for both.
Okay. And so you also bring up a good point around, I think, distinguishing between kind of like the beginnings of kind of substance use addiction among adolescents. And so as you think about that and you think about the statistics, what would you suggest in terms of screening youth for substance use issues? Like at what age would be a good age to do that? Because in a lot of behavioral health clinics, they are seeing youth coming in. So if you had to kind of give a best practice around that, what age is a good age to begin that screening process?
That's a really good question, and I don't want to go ahead and give a concrete age. We've been looking at what some of the other states have been doing, and some states have even started in elementary schools and training the school nurses just to be kind of like on the lookout. So I think really the best answer is that no age is too young if you're starting to suspect it, because as the research shows that the younger someone is, the more at risk they are. So I hope that helps answer. I can always look up some more information and get that out to anyone who's interested.
Okay. And if I can also just add on to that, I think another important element is that I think age is important, but also in addition to age, you want to look at signs and symptoms. So you might have an 8-, 9-year-old that might be displaying symptoms that might be alarming. So those are things that I think are also important to keep in mind as well. That if you're seeing again, signs and symptoms that are unusual in a child, you should seek some type of medical attention or some type of intervention with an addiction professional, with someone in the medical field, and even addressing it from that perspective, that professional should be able to make a referral to someone that is an addiction professional. So my point is that anything that's unusual that you may see in a child or adolescent, you will need to get attention for. And that can go from the very early ages all the way up through adolescence.
Thank you. Another question is, someone has asked, how do the presenters feel about using a shared medical appointment model as a potential treatment model for substance use disorders? Are you familiar with that? Do you have any experience with that?
Well, I'm not quite sure what you mean by shared medical model, but I'm going to take a stab at it, and I think what I'm kind of hearing in that is really looking at an integrated care approach. So, for example, if a medical doctor sees someone in his or her practice and they may see some signs of substance use or addiction, that within an integrated model, they can make a referral to an addiction professional. So if we're looking at shared in that way, I would say that it is definitely an excellent idea, an excellent approach, and a direction that I think the field is definitely moving in, where we're looking at integrated care and we're looking at access to care in many different arenas. But addiction is definitely one of those arenas where I think the medical profession and healthcare providers really need to collaborate more around the treatment of addiction.
Yeah, agreed, and I think you said it. We'll talk in the future about some of the transformational things that are happening in that field. Another question is, would the disease model, would the disease model be a good model to use to help chronic marijuana smokers?
I think in terms of addiction, the science is really starting to show a stronger and stronger evidence base around the biochemical changes from addiction. So if I were to put marijuana use in there, which I am, I would say that in terms of all addiction, we are seeing changes in the brain structure. So to answer your question, I would say that yes, when we look at addiction as a whole, science is really demonstrating a neurostructural change in the brain because of substance use.
Yeah, and to that end, Marcus, there's another question that kind of a follow-up to that. So the attendee asked, does alcohol also have the same effect on the brain as other substances such as heroin or cocaine or crack? And if not, how is it different?
I think what the similarity is that with chronic use of any substance, you are going to get changes in the brain structurally. Now, what may differ is the type of symptoms that you may have. I'm sure that with some substances there's some overlap with some symptoms, but I'm sure with other substances there could be some slight distinctions. So, for example, someone that uses cocaine, the symptoms for cocaine use could be different than the symptoms for someone that's consuming alcohol, for example, or abusing alcohol. So you're going to get some changes or some differences in symptoms, but I think structurally, in terms of the brain, you're going to get definite permanent changes over time.
I'm just going to add one more thing to that, too. I know we talked a lot about dopamine today, and that's one of the main ones that are impacted. But different substances also act on other neurotransmitters in the brain, so different substances can affect those in different ways, but they still are affecting the brain.
Okay, thank you for that. There's also a question around relapse and recovery and thinking about folks who perhaps may have been in recovery for a substantial amount of time, and then you find that they have relapsed. And so just really trying to, I think, understand that process and why that might occur. Do you have any thoughts about that?
Yes, I think part of the process is, and I think the science has shown that with evidence-based practices, MAT for one, you can manage one's addiction. But also, what we talked about earlier was that really addiction is not an acute care episode. It's really something that has to be managed over the course of time. So over the course of time, there may be periods where a person may have cravings or may relapse. But what that means is that you still continue to help the person to treat the symptoms of the addiction and the addiction. So the point I just want to make is that managing addiction really is like managing any other chronic condition one may have. If one has diabetes, there may be times where one's sugar level is higher, and then it may call for a different intervention. So really addiction in a lot of ways is looked at in a similar way.
Great. Thank you. There's a question around evidence-based practices and information and whether or not there's some evidence that suggests that the effectiveness of trauma-informed treatment for individuals who are dealing with substance use disorder issues. Do you have any knowledge regarding that?
Really not much in terms of, I mean, what I'm saying is that I'm not very familiar with that. I know that there is a body of research that shows the effectiveness of interventions around trauma, but what I would say is that the evidence that we do have and that we do know is that, particularly with MAT, that there has shown a correlation between treatment effectiveness and the use of MAT, which is medication-assisted treatment. So I really can't speak a lot to the trauma research, but I know that there is trauma research that's out there that is available and that there is some link. I'm just not quite sure what that link is.
Okay. And I know you mentioned that we'll, in the future we'll be talking about some of those, again, transformational elements, but we know that people with mental health challenges are more likely than people without these challenges to experience an alcohol and substance use disorder. And research does suggest that these individuals are best served through an integrated model. Can you talk a little bit about whether or not you think how the field is moving, just general in terms of some things that as a provider you can be thinking about as you work in the future? Like, how is the system going to really embrace kind of like an integrated treatment model? Any thoughts about just some of the changes that are happening?
Well, I think that this is just really an exciting time in healthcare, and I think the reason why it's so exciting is the fact that we are moving towards more of an integrated model. I think that when you look at behavioral health and when you look at healthcare in general, integration is really going to lead to a more holistic approach in terms of how we treat the individual. So we're not just looking at an individual from one perspective, but healthcare providers as a whole, either in collaboration or through increased expertise, will be able to address multiple issues or to work in teams to address multiple issues that an individual may have. And I think that that is something that we didn't always have in healthcare, but we're definitely moving towards that. And a lot of work that is being done in the industry and in the field is really driven towards that. So we're looking at things like, for example, access, for example. We're looking at being able to get people into treatment quicker. We're looking at being able to address issues in a more timely manner. And that all is the benefit of having an integrated care model. So I think, again, just to summarize quickly, the direction that the field is going in terms of healthcare and integration is really going to have great benefits for people that are seeking treatment for various types of conditions.
Great, thank you. And another question is around your thoughts or experience with the effectiveness of support groups such as AA and NA, and whether or not those have proven to be successful, and maybe perhaps pieces that someone should be thinking about if they have an individual who's in need to be able to connect them to those services. You have any information or could share your thoughts on that?
Just a quick thought. I think that groups like AA, NA, and other mutual aid groups are really beneficial in collaboration with an integrated treatment approach. So the point I'm making is that using those approaches in collaboration with other treatment approaches and other types of treatment, I think as a whole will help to improve the conditions of folks with addictions. So my point is that it's just not one particular approach, but it's several approaches in combination. To give you another quick example, the use of MAT in collaboration with counseling or individual counseling and group counseling is more efficacious. So again, I think the research is really showing that when you use a combination of approaches, you tend to get better treatment outcomes.
Great. And I think one of our last questions was around some of the stats, again, that were mentioned. It said it was discussed that genetic disposition may have a role in substance use. What evidence is available in regard, and can you talk a little bit more about that, maybe just briefly, what you know in terms of that?
Yeah, so it's pretty high. I don't want to speak to exactly a lot of the research around it because I haven't done a lot of, dive into these individual studies. I do know that there were some twin studies that were done to look at twins, and that show that, and then also between parents, and it seemed like if a parent had an addiction, offspring were about 50% more likely to have it. So there is definitely research out there, and the research is strong to support the genetic part of that. So yeah, it's pretty high.
Great, thank you. Well, we don't have any more questions, so we're going to go ahead and move forward and close out. But we want to thank you, Marcus and Tiffany, and thank everyone for attending today's webinar. If you have any other questions, you can contact us at ctac.info@nyu.edu, and we will do our best to respond promptly. We also want to let you know that once you leave today's webinar, you will receive a survey in the presentation, and we would appreciate if you would complete that and provide your feedback. As a reminder, it would be very helpful to us because we are building out a number of these webinars, and so it's great to hear your feedback. And on behalf of CTAC, our partners and presenters, we'd like to thank you for joining us today and have a great rest of your day. Thanks so much.
Thank you.